computer. Okay. All right. Respiratory system and the medications. Find my mouse again. So this unit is the last one that's going to be on the exam that's next week. And so again, sort of some of the pathophysiology of the conditions that we're going to talk about, and then medications. Objectives: identify the function and anatomy of the respiratory system. We're going to discuss allergic rhinitis, asthma, and COPD. That's pretty much it for the rest. There's other respiratory things, certainly, that we could include, but those are kind of real more common. The medications associated with those are probably going to be more common ones that you might see in practice. So we'll talk a little bit about the anatomy around some of that stuff, the function, what happens with the disease, complications, and then the drugs that are associated, therapeutic effects, the mechanism of action, and then adverse effects. So you can kind of start to get the rhythm of like, those are kind of like the main things that you want to know about the drugs. What's it for? Sometimes categories or subcategories, mechanism of action and effects. So just a basic, real basic anatomy of the lungs. Air comes in through our nose, ideally. Obviously, we can breathe through our mouth, but you're supposed to breathe through your nose. And then it comes down through the pharynx, and then down into the bronchioles and the alveoli at the very end. All these little tiny sacs, and this is kind of blown up. And that's where the oxygen and CO2 are exchanged in the circulatory system. So, and then there's all the other stuff, trachea, esophagus, all the things. You're not going to be tested on anatomy, but that's just kind of your overview. And this sort of says the same thing. Air entering the respiratory system travels through these areas. And then the tracheobronchial tree kind of divides and splits off more and more and more until you get to the alveoli. And the alveoli kind of comes into play with some of the diseases that we'll talk about with asthma and COPD. And so, which airways are surrounded by smooth muscles? So everything has, our vascular system, lungs, the alveoli, everything is surrounded by smooth muscle. Which receptor can you think of from a previous chapter related to smooth muscle? Anybody? Beta 2, you guys are thinking of beta 2. But what else was smooth muscle? Alpha 1, right? Yeah. So alpha 1, that's the one that I kind of lump in with the smooth muscle, and then beta 2 is lungs. Beta 1 heart, beta 2 lungs. But this is a handy dandy chart. I like it because it kind of zeroes in on what we have learned, focusing more sort of on the lung aspect. So we have alpha 1. The organ that we're mostly talking about today is lungs, and the response, if it's doing what it normally does, if an alpha 1 receptor, takes on, a chemical or whatever, and it's going to encourage its alpha 1-ness, what it would naturally do, it's going to have smooth muscle contraction. So in the lungs, if alpha 1 is stimulated, it's going to contract the smooth muscles, and that would close down your lungs. In the vasculature, it closes down blood vessels, so vasoconstriction, and that is a response to stimuli, or that's what it naturally would do. For beta 2, we know that beta 2 was more for the lungs. We kind of talked about that. Beta 1, heart, beta 2, lungs, but this just kind of summarizes it. When beta 2 is stimulated and triggered in the lungs, it does vasodilation. So if we block beta 2, we're going to have that opposite effect. And then in the receptors that are in the heart can contract, increase contraction, so increase heart pumping. And then vasculature is going to dilate. So it does different things, the different receptors in different areas. But we are kind of predominantly thinking about how beta 2 affects the lungs for this unit. And then we have a new one. We talked about, do you guys remember I was talking about H2 from the GI when Dr. Fortner was here? So H2 in the stomach, H1, predominantly we're talking about in the lungs and the eyes and nose and all this stuff. because H stands for histamine. So histamine 1 in the lungs, if it's triggered, we're going to get bronchoconstriction. We're going to get bronchial mucus secretion and congestion. In vasculature, we're going to get nasal, if histamine is triggered and we get a histamine reaction, we're going to get nasal mucus secretion and congestion, hives, edema. Think of all the allergy stuff. Eyes, vasodilation. So we get our red eyes from an allergy reaction. And then leukotrienes is another one that we haven't talked about. We'll only really talk about it in this unit. And that, the way it affects, if the leukotrienes get extra stimulated and overreact, then in the lungs, again, we get this bronchoconstriction. So you can think of all the stuff that kind of like, you have a respiratory infection, you just don't feel like you can breathe as good. When you're congested, like, oh, I just can't breathe. Everything like closes down in the bronchioles. And except beta 2 is sort of our outlier. If it's stimulated, it does bronchial dilation. And that's where our medication comes into play, our albuterol and our those medications. So we'll get there in a second. So I like that. It summarizes kind of, you'll really want to know this chart. Be comfortable with this chart. Okay, so the respiratory diseases that we're going to talk about: rhinitis, asthma, COPD. So for rhinitis, basically it's just nose inflammation, right? Just rhino is nose, like rhinoplasty, and then itis is inflammation. So rhinitis is just inflammation of the nose. And then more than 50 million Americans are living with nasal allergies, can be nasal eye allergies. It's all connected. And so you feel it in different ways. They might have seasonal allergies. Men are more likely to have those kind of allergies than women, but I feel like I just feel like everybody has some kind of allergy to some degree. And it does appear like allergies are on the rise. Like if you compare how many people had allergies in the 80s, maybe late 70s, the amount of individuals who suffer from some kind of an allergy has pretty significantly increased over the decades. So etiology of rhinitis, if it's an allergic rhinitis, then most people are going to have it from pollen, mold, dust, pet dander, mites, like all kinds of funky things. I just was listening to a talk, and the guy he's a pastor, and he went and lived in Australia for a number of years, never had any allergies at all to anything, nothing. And he went to Australia and was severely allergic to mites that would be like in the carpet and stuff like that, which, I mean, it's gross, but we have that too, like if you, like, that's just what happens in life, And so if he went into like maybe an older person's home where, maybe they'd lived in the house and the carpet was older or something like that, he would just like explode with allergic reaction in his eyes and nose and everything like that. And he took him a while to figure out what it was, but that's basically what he came to. The decision was that it must be or maybe he got tested, I can't remember. But anyways, so, mold spores, rye, ragweed, all these other things can cause a reaction. Viral rhinitis is just the common cold. There's 200, there might even, this is actually, this number is this is the same number I've said for the last 7 years. Every time I teach this class, I'm like, there's 200 plus viruses. Maybe there's 400 now. I don't know. Viruses like change and replicate and stuff. So there could be more than that, but there's a lot of viruses that just alter slightly, that cause the common cold. And that's why, the joke was like, if somebody found a cure for the common cold, they'd be like a zillionaire, but you really can't, because viruses change too much. They mutate and they change too much. So there's no like vaccine, although I know there are a few that they've put out on the market that are new. But in general, like for like the common cold, not like flu, but like the common cold, there's really not much you can do, but just live with it. And the common cold does come from coronaviruses, rhinoviruses, adenoviruses, respiratory syncytial virus, they do have a vaccine now for that, but okay, so what causes all of this? So what happens when somebody has an allergy is we have these things called mast cells. You guys probably have studied them in some of your other classes, I imagine. So we have these mast cells, and all along the outside, is these little proteins that live on the surface of the mast cell, and they're allergy antibodies. They're like a protein that just binds to the outside of the mast cell. And if something like pollen or pet dander or something comes along, it can bind to those antibodies, those receptors on the outside of the mast cell. And on the inside of the mast cell, we have all the histamine. So all of these little globular things on the inside are sacs of histamine. So in people who have severe allergies to whatever, pollen, pet dander, mold, when those little particles land on these antibodies, it ends up releasing the histamine, and your body just kind of like overreacts. And it just takes that histamine, and that binds to all our histamine receptors, and your body just sort of acts like it's some kind of a bigger invader than it really is. And then we get a downstream effect of itchy, watery eyes, runny nose. It can run down into your throat, make you cough. So nasal congestion, rhinorrhea or runny nose, itching, sneezing, mucus production, all the good stuff that probably all of us have experienced a lot. This video is super good. I played it to make sure the link still worked, and it did do a funny thing where it's Khan Academy. Have you guys seen that before? I feel like that's pretty common. You might have even seen this video before. If they played it, like, I guess I feel like this is geared toward even high school, so I don't know. But I really like the way it goes through just allergic rhinitis and what's happening inside the nose. So I would click on it. There might be something that comes up that's kind of like, pay for Khan Academy, but I just X'd out of it, and then I was able to play the video. And it's like YouTube-based video, so you should be able to just bypass it. But it's just basically says what I already said, but I like the way the guy describes it, and he draws good pictures, and it just it makes that kind of flow of events make more sense. So I think I don't know that I have time to play it, so I'm just gonna put that on you guys to watch it on your time. Okay, so treatment for allergic rhinitis, obviously you could try to avoid seasonal allergies, which a lot of people have a challenge doing. I have, just on a side note, you guys have probably all heard of like neti pots, the nasal flushing, things like that. I swear that stuff works. And they do that more in some countries. They do that more than I think here, but I love that. And I don't ever like a lot of water in my face. Like, I'm not a go underwater and swim a whole bunch, but I don't mind flushing out my nasal passages with a neti pot or with a nasal flush. And I swear it cuts down cold symptoms, and there's a lot of good research that says it keeps the pollen or whatever's irritating the nasal passages kind of rinsed out. So, so those are some kind of non-medication things that you can do. But then there are medications to treat the symptoms, which are pretty obnoxious. It's pretty horrible to have really bad allergies, be stuffy all the time. So allergies versus cold symptoms. So what works? So what do you use to treat cold symptoms? So what are some things you might use if you have a cold? Or if you have an actual cold, yeah, like a viral cold. Sudafed, did I hear Flonase? That might be for allergies, but that's allergies. But decongestants, yeah, like Flonase. I mean, like Sudafed. NyQuil, yeah. Mucinex, yep, all that over-the-counter stuff. What would you definitely not take if you had a viral cold? What prescription would you definitely not take if you had a cold that's caused by a virus? Antibiotic, right. Okay, so we're going to talk about some of the different meds. So the drug families that we're going to basically talk about for this category are mast cell stabilizers. So they kind of make the mast cells not as reactive to release the histamine. Then there's antihistamine. So these are going to block, like if the histamine gets released, it's going to work on those histamine receptors to kind of block it. And then there's decongestants, which are going to work on like alpha 1 and some alpha and some beta as well to kind of, it says open things up, but honestly, what they do is close things down so that you're not as red and inflamed. But it ends up, the end up result is that you're clear, like you can breathe. So that's what I mean by open things up. It makes you not congested. But on a cellular level, it's actually vasoconstricting. And then calm things down, the steroids, anti-inflammatory, and they end up being anti-mast cell, histamine, all of that stuff too. So the first one, mast cell stabilizer, it is an inhibitor used to prevent and treat the symptoms of allergies. The mechanism of action is it's a blocker, so it's an antagonist. So a mast cell stabilizer is a blocker antagonist. It inhibits the release of the histamine within the cell, so it kind of makes the mast cell not release the histamine in the first place. And therefore, it also has a sort of an anti-inflammatory effect as well. And the thing about mast cell stabilizers like nasoprom is a popular one, over-the-counter inhalant. It doesn't tend to work like 100% right away. You have to use it for a little while. So you might start it before the height of seasonal allergy season. If you know something's going to come into bloom in April or March or February even, or so I worked with a lady who was allergic to like Christmas trees, so the pollen of fir trees, she was allergic to them. So around she could never have a real Christmas tree in her house because she was allergic to that. So anyways, you want to start it earlier because it doesn't work right away. And antihistamines, they prevent and they treat the symptoms, and they are also blockers. So they're going to be antagonists. And these medications block the histamine from binding to H1 receptors. So they've been released from the mast cells, they've made their way to H1 receptors, but the medication gets there and blocks those receptors, and then it makes it so that the symptoms aren't as obvious. So with antihistamines, we have this first generation, second generation, and I want to say Dr. Fortner touched on this a little bit, first generation, second generation, but can't remember, I can't bring up any examples specifically, but they'll find a drug and then it might be great and work really well, but maybe it has a lot of side effects, and they work on the molecular structure and they're able to change something, and they come up with second generation drugs that typically they tend to be better and in some ways, but sometimes they're not as effective in other ways. So sometimes doctors will not like the next generation, but others will because they're fighting a side effect that they don't like.
Yeah, sometimes like the hyperlipidemia first action, secondary action.
Yeah, the hyperlipidemia with the high blood pressure medications.
It's like reducing LDL and total cholesterol, or increases HDL and reduces triglycerides, secondary action.
But that's with the same drug though, right? Yeah, this is actually like two totally different drugs. Yeah, good question. No, thank you. That was good clarification. But yeah, they're actually like two different drugs, and this will make more sense, I think, with my next slide. So, because I'll actually name the drugs, it'll help clear it up. But it's the chemists, they come up with a first generation drug, and then they keep working on it, and then they come up with a second generation. And sometimes there's third generations too. But a lot of times with these first versus second, there's equal efficacy, but they're usually going to have more side effects in the first generation, and they work on that, and they're able to make them have less side effects with the next generation. The time to relief with an antihistamine is a lot quicker. Like you could take a Claritin or something like that and get some relief pretty quick. And then major side effects is xerostomia. And this topic, I think we talked a little bit about too in the beginning. A lot of the receptors are cholinergic receptors in the parasympathetic system. And so if something is anticholinergic, I wonder if this will ring any bells. And Dr. Fortner talked about this too. If it's anticholinergic, if it's blocking cholinergic receptors, we end up with a lot of the side effects of dry mouth, dry eyes. Can't urinate, and you can't defecate. And so that's that SLUD you'll see that written. Pharmacy students, would refer to that a lot. SLUD, there's a little overlap here, but it's salivation, lacrimation, urination, defecation. And so we get that anticholinergic effect with quite a few medications, actually. And then drowsiness and sedation varies depending on the drugs. So leukotriene modifiers is another one. So we have mast cell stabilizers, antihistamines. These are all different categories that you want to kind of parse out. Leukotriene modifiers, an example of a leukotriene modifier is Singulair or Montelukast, also known as leukotriene receptor antagonist. It's a blocker. Those are all kind of synonyms of each other. Blocker, antagonist. Approved for the treatment of seasonal and perennial allergic rhinitis. Mechanism of action, it blocks the effects of leukotrienes or stops your body from producing so many leukotrienes. Maybe some people just like to produce leukotrienes. Adverse reaction, generally well tolerated. Post-marketing, there's like a probably, hopefully rare post-marketing reports of psychiatric symptoms, thoughts of suicide, and sleep disturbances. So take it, risk benefit analysis, but that's post-marketing reports. And a lot of times, they don't always reveal all that stuff when they're trying to get a drug to market. So that's post-marketing reports. Okay. Oral over-the-counter antihistamine. So this slide probably should have gone before the leukotriene one. I feel like it's slightly out of order, but now these are antihistamine drugs. So these are the antihistamine drugs, first generation, second generation. Your common drug that everyone's probably taken at least once in their lifetime is Benadryl. That's a first generation antihistamine. It has a high sedation. It has a high sedation side effect, and that's why some moms use it on their kids for putting them to sleep. And then it has a high anticholinergic effect as well. So it can really dry you out, really cause dry eyes, dry mouth. So that's first generation. Chlorotrimazine. Have you guys heard of that one? That's to me is a common name. I remember hearing it just in general, like, I don't know, like my parents had it in the house, but that's another over-the-counter, little bit lower in the sedation and kind of a moderate anticholinergic effect. So those are first generation. They've been around a long time, been on the market long time. And then second generations are all the ones that you guys are probably also familiar with: Claritin, Zyrtec, Allegra, loratadine, cetirizine, foxofenadine. And notice all of these are low for sedation and low for anticholinergic, but I think they still can dry you out. And some people more than others. I take one Claritin and I'm dry as a bone. So I just think it affects everybody different. So first generation, second generation. So there's probably questions on that on the exam. So you just want to know what's being talked about there. Okay, this is just a chart that kind of shows the same thing. It's got some of these drugs and the different bars are antihistamine efficacy, anticholinergic activity, and sedation. I'm not going to test you on anything here. It's just another visual way of looking at the drugs and some of their side effects. For Benadryl, Claritin, chlorotrimazine. Okay, so another category. So we have antihistamine, mast cell stabilizers, the leukotriene, and then now we have the decongestants. So decongestants are sympathomimetic drugs. They treat symptoms, mechanism of action, vasoconstriction in the nasal mucosa. So it's works on the alpha-1 adrenergic receptor. So adverse effects here because they, for whatever reason, it kind of, it's not anticholinergic. So it just, but not everything that causes xerostomia is anticholinergic. So, what?
On the last slide, the last two slides, you said we can know, like that table, but you know, like the high and low cholesterol.
You don't need to know. I mean, I would encourage you to know that Benadryl causes dry mouth. Like that's a very like significant common side effect of Benadryl. That is something I think you should know. If you have a patient that takes Benadryl a lot and for allergies, or maybe they take it at night, and because it's sedating, so maybe they take it at night, but they take it regularly, then you have them in your chair and you notice their mouth is dry, then you would want to have that conversation with them about why they potentially, have dry mouth. So that's any medication that causes significant xerostomia, you would want to kind of memorize that and know that.
The sedation that's talking about right now.
Oh, that's the anticholinergic.
Oh.
It's high for both. It's high for dry mouth and sedating. Benadryl is, yeah. And I do think that that's important for you to know. Yeah. So yes, so some of this, and this stuff is all just lower with the sedation and low to moderate for the anticholinergic effects, which essentially the main effect that we're talking about there is the dry mouth, although it can also make your eyes dry and other things as well. So other adverse effects for the pseudoephedrine or ephedrine or the different, Sudafed is the brand name, is it can, because it's drying things up, you can get some stinging, burning in the nasal mucosa and dryness there. The effects of the alpha receptor in other parts of the body, it can have a mild increase on blood pressure and heart rate. Like it's related somehow, it's molecularly different, but there was the weight loss, or back in the day, people would take ephedra and it's like a raw material for meth, I'm pretty sure. Somehow you can use Sudafed to make meth. Don't ask me how, but it's kind of related to that, like almost that speed concept. Like you can think, it kind of amps you up. And so if that helps you remember that it can increase blood pressure and heart rate, there's a workaround for you. And no exam questions on how that actually functions, because I don't know. Never made meth, but I know that they used to make it illegal for a while in the early 2000s. You couldn't get Sudafed at Walmart or whatever in Oregon. That you had to.
You can't. So
you
like a certain level.
A percentage. You have to ask the pharmacist for it. Yeah.
Or you can get it in Washington though.
Yeah. Yes. A lot of states didn't change. Oregon, it's like pumping gas. Like couldn't do it forever. Okay. And there can be a little bit of a rebound effect, which means it might work really well for a little bit, but if you use it too much, too frequently, it might stop working as well. So there's a little bit of short-term use for any of those. And hopefully if you're using it for cold symptoms, you would just use it short term. The doctor I worked for, one of the other medications that we'll talk about, I think it's Mucinex or Afrin. I think it was Afrin. He would use it and he got the rebound effect, like it stopped working. And so I've never had to use those kind of medicines before, but I remember him coming in to work talking about that and how he used it so much and it stopped working. So I kind of learned about that before talking about it this way. But so these are some of the meds, some of the decongestants. There's oral, like liquids and pills, that's the pseudoephedrine or the Sudafed. Over the counter, these are all over the counter. And then the phenylephrine is an intranasal spray. And we have different kind of iterations or different brand names. And then another drug, this Afrin, that's also an intranasal spray. So just some different drugs. These are all under the category of decongestant. So Afrin and Sudafed are probably the only ones, if they're going to be on the exam, that I would ask you. Okay, last category. There's a lot of different, but I mean, you go into the cold and flu aisle of the grocery store and there's like this is like all what's in there. So all of this pretty much is, for the most part, over the counter. Some of those drugs started out as prescription and it's kind of like some of the GI drugs. They started out as, the GI drugs started out as prescription and then like they went to over the counter.
Is there something in Afrin that's different than Flonase that can be addictive? That's what
It could be because it's part of that ephedrine. I think it has that same, I don't know for sure, but because it has this same, like no, they all end in that INE. So I wonder if it's, because that is something that they for sure talk about with pseudoephedrine. So oxymetazoline.
I just heard that there's some nasal sprays that people get addicted to, and that's why they stop
Yeah,
working because they overuse them.
because they overuse it. That's the rebound effect.
That whatever that is, it's not in Flonase.
Yeah.
I asked my doctor about that.
Yeah, and Flonase is a different category. I'll have to look more into that. I'm really not sure, but I will have to ask because the Flonase is under the intranasal corticosteroid, so it's like a steroid. But there are some things your body can also kind of get used to a steroid too, but I wouldn't be like an addictive thing, I don't think. Like the other one might be. I'll have to look it up.
Yeah, I just have family tie. Like my stepsister is addicted to nasal sprays. Yeah,
That's awful.
I know.
Just
over the counter.
Yeah. But was it giving a different benefit than just clearing out her nose?
No.
It was clearing out her nose, and that's what
Yeah,
she wanted to do.
that's what she wanted. Like,
Yeah.
I just stopped working.
Oh, and then
so
it's
I have allergies, so they prescribed me Flonase, and I was over the counter too.
Yeah, because it was originally a prescription.
Yeah.
That's how my husband got it the first time.
Yeah, and I asked them about it with my sister, and they were like, "No, it won't happen with."
Am I gonna get addicted to Flonase? Yeah. Well, every morning, whether I have a cold or not, I squirt this. It has xylitol in it, so it has like an antibacterial. And who's the maker of it? I can't remember, but it's just like saline, and then it has some xylitol in it, and it's like a nasal flush. And so I do a squirt up each nostril every morning.
Oh,
and if
nice.
I feel like it's flu season, I do it morning and night, and it just kind of flushes you out. Okay, I like it. So intranasal corticosteroids, these are over the counter, but just like Ellie was saying, a lot of these drugs, they might start out prescription, and then I don't know if they lower the dose or they decide they'll sell more if they put it over I don't know what it is, but they do transition from prescription to over the counter. But these drugs treat inflammation. The mechanism of action, you can see it inhibits things like mast cells, and the mediators around all of that inflammatory process. So histamine, leukotriene, prostaglandin, and others, etc. So in general, it just kind of helps inhibit those inflammatory cells. And then time to relief is not instant. It takes a couple days. And then there can be, again, the stinging, burning, dryness of the nasal mucosa. And so those are, and you can see that they're similar, like there's the fluticasone for the propionate and then the fluticasone furoate. So they're very similar, but there's some other molecule. And the second one there is a prescription. And then there's mometasone, Nasonex, which that dosage is a prescription as well. So there's just usually just small variabilities that make it, either over the counter or prescription. So this is just a way to think about it. You could add the drugs. I still think flashcards is probably the best. But just to remind you that you want to know any drugs that are in red are fair game. You want to know the mechanism of action and then adverse effects. And for a lot of those that we just went over, xerostomia, maybe some sedation, dry nasal passages, maybe burning or stinging. That was kind of it for a lot of, so they're kind of repetitive. So this is not super hard section. The harder questions are going to be the mechanism of action. Those are going to be the harder questions because those are different. They work on different things. So those are the ones you'll probably have to spend a little bit more time on. So how are we? We go to 250. Is that right? Okay, let's take 5 minutes and then we'll come back. So come back at 2:05 and then we'll finish up. Resume recording. Okay. Okay. So we're gonna do a case. We're gonna look at this case. A 28-year-old female is returning for a routine dental cleaning. A few days ago, she came down with a cold. Her symptoms include watery and itchy eyes, sneezing, and nasal congestion. She denies having coughing, aching, fever, or chills. She's been taking Benadryl every 4 to 6 hours as instructed on the box, and it helped with her itchy eyes, watery eyes, and sneezing, but she feels zoned out and tired, and she still is congested. Um, and she's still congested and has not been getting quality sleep. She breathes through her mouth and believes it's why her mouth is so dry. So just a lot of stuff there. So explain why would Benadryl help her itchy, watery eyes, but not help with her congestion?
It's just and patients will love me.
So it's more like just for allergies, kind of, right? So it's not like she could have, what would she maybe have? Could she maybe have like a viral cold? I didn't know how to ask that without just telling you my answer. So she kind of is treating it. It says, she came down with a cold, but she's kind of treating it just like allergies. And so she probably has a virus. So it helped with some things, but the viral part of it didn't really get addressed with the Benadryl. So which drug may be better for relieving nasal congestion? Sudafed, or all the other things we talked about. And then what may be causing her dry mouth? The Benadryl. And also, this is kind of a sneaker one, but she's breathing through her mouth at night. So even though she does believe that's why it really could be causing her dry mouth in coordination with the Benadryl. It's probably the Benadryl too. So you would want it. So if she doesn't know that, then that's part of your role as the dental hygienist to say, oh, your mouth is probably even drier. Like breathing through your mouth at night, yes, dries out your tissues, but taking Benadryl like really amps that up. It's probably mostly from the Benadryl. So what drug may be better for relieving her itchy, watery eyes and sneezing that would cause less anticholinergic effects? Zyrtec, Claritin, yeah. I did not check this link, so that's a surprise link. I don't know what it is, but it might be something good. So we're moving on to asthma. So it's probably the mechanism, the pathophysiology of asthma. So it's probably a good thing to watch. Asthma, the definition, I want you guys to kind of, if you get an exam question and it gives you a definition, just try to kind of pay special attention to the difference between the definition of asthma and like COPD, bronchitis, because there's different things. So asthma is chronic. It's a chronic lung disease, and it's characterized by bronchoconstriction when it gets activated, bronchoconstriction and inflammation, mucus production too. Asthma prevalence is higher in adults than in children, although I feel like kids get it a lot, but sometimes they say kids get them and then they grow out of it. Females, it's a little higher in prevalence in females than in males. And this is just some pathophysiology, kind of like what happens a little bit step by step. So we get some airway inflammation, and the asthma attack is triggered. Get some airway inflammation. which is from things like these immunomodulators, T lymphocytes, eosinophils, different immune system markers in the white blood cells that are involved in the inflammatory response. We have all kinds of them. We know they're involved in all kinds of things. We even talked about, you learned about in Ontario. And then there's leukotrienes as well. They're inflammatory mediators. There's the mast cells. They're going to release the histamine in response to allergens. And then there's mucus production, retention, and plugging. So that is when the mucus like stays down in like down deep into the lungs and like basically kind of does exactly what plugging kind of plugs it up. It's hard to get it out. It the whole lumen of the airway gets kind of shrunk down and coated and thickened. You get a lot of swelling and constriction. You can see the difference there. And then the next, so the kind of steps 3 and 4 and 5, we have then when there's bronchospasms, and that's that really squeezing feeling in the chest. It would be very scary, especially if it's a severe asthma attack, mediated by the beta-2 receptors. And so if they're getting a bronchospasm, they're getting constriction, the beta-2 is, what's happening with the beta-2? Is it being activated or blocked? Yeah, because it's constricting. So we want something that's gonna open it up and like have that, like we don't want it blocked. We want the vasodilation. So, and then lung hyperinflation or air trapping. I used to have a question on this. I don't remember if I still do or not, but you might want to highlight it just in case. It basically means that it's a weird thought because when we think of asthma, we think, oh, they're not going to feel like they're getting enough oxygen. But what happens is they get a hyperinflation and the air can't come out. So then if air can't come out, fresh oxygen can't go in. So that's what that means, this lung hyperinflation. This is more of like this real severe asthma attack. Hyperinflation and air trapping. So you just don't have the coming and going naturally of the air and oxygen. And then overall, there can be airway wall remodeling in chronic asthma, which basically means like the healthy, normal construction of your bronchioles, your lungs and everything changes. It gets remodeled, like if you're going to remodel your house, but not in a good way. You don't want that. It's the same thing with bone loss. We talk about bone remodeling. Things are changing, but not in a good way. It's changing the structure. So that's what remodeling is. Okay, so some triggers for asthma. It could be allergies, just like what for allergic reactions. It could be pollen, plant smoke, animal dander, exercise, stress, changes in weather. I've heard people say that severe thunderstorms and things like that. I'm not sure why, but that's a thing. Upper respiratory viral infections could trigger it as well. They have a severe upper respiratory infection. And then if this looks slightly different from yours, I tried to refresh it, the one in Moodle, but I might have to do it like again because I think this said a month mistakenly, and I looked at that and I was like, that's not right. And so I changed it right before class, and I thought it saved in your Moodle, the one that's in Moodle, but it might not have. So I will make sure that that's accurate. But these are the different sort of categories. There's intermittent, which someone would have an asthma attack less than twice a week, and the symptoms would not interfere with normal activity. So they might still carry an albuterol. They're going to be the kind of patient that comes into the clinic and they mark asthma, and then you're like, did you bring your inhaler with you? Because you need to have, and they'll be like, oh, I never bring it with me. Because they probably don't really feel that much of an effect. It's very intermittent. It's mild. They're not the kind that like have an attack that they're worried about. And so they leave their rescue inhaler at home because they're not worried about it. And that absolutely has happened. We've had patients like that. And then there's the mild persistent, which happens more than twice a week, but not daily. And then awaking from sleep is less than 2 times a month. So it's really not disturbing their sleep. It might slightly affect their daily activities, but not significantly. And then there's the moderate persistent. That's going to be someone that's dealing with it much more. Symptoms can happen almost daily. And then severe and then status asthmaticus. Did you guys learn about that in medical emergencies? Maybe, maybe not. You don't know. A severe condition.
We haven't learned about it yet.
No. Okay. You haven't got to respiratory yet. A severe condition which asthma attacks follow one right after another. The inhalers are not working. That patient needs to be in the hospital and get medical attention. And so if they ever put on their medical history that severe asthma, you might say, have you ever been hospitalized? Have you ever felt like your asthma attacks couldn't get under control, and just asking those kinds of questions.
What does sports-induced asthma go under? Have you heard of that?
Yeah. And I mean, I think it depends on how often it affects you. So like if someone does a lot of sports and like the training and all of that kind of stuff and the workouts, it makes it happen more than twice a week. Maybe you have to use your inhaler, but it doesn't really interfere with sleep. Then you might put yourself, if you have exercise-induced or sports-induced asthma, you might put yourself under mild persistent. So I think it still has to ultimately fall under these timing. So it just depends. There could probably be very mild sports-induced asthma.
But from like a clinician's aspect, we don't need to worry about that to say that.
I don't think so. I would just ask them like how frequently, what do you do to take care of it? Just like someone with angina. Do you have your medicine with you? How often do you have them? What do you do to make it better?
Okay.
Good question. Okay, so signs of asthma: wheezing, coughing, difficulty breathing. Dyspnea is difficulty breathing, chest tightness. I'm gonna skip because we're running a little bit behind on stuff. So treatment for asthma, eliminate the triggers if it's, something significant, and it's difficult to handle the attacks, then we probably have to. I've heard of people with severe asthma having to, use special filtrations in their house, special filtration systems and different things. Can't have pets, different things like that. For pharmacological therapy, we're gonna learn about them here in just a minute. But these acronyms, SABA, LAVA, we used to have a student named Saba, so I'm always like, oh, Saba. But so SABA, LAVA, ICS, LAMA, and LTRA. And this is what they stand for. And so we're going to kind of talk a little bit about them. But they're short acting beta-2 agonists. What I like about it is that's like the mechanism of action. It doesn't last very long, but it's a beta-2 agonist. Long acting beta agonist, inhaled corticosteroid, long acting muscarinic antagonist. We haven't seen M for a while, muscarinic. And then glucotrene receptor antagonists. These two are agonists, these are antagonists. So we'll look at those a little bit closer. And then before we get to meds, I'm just going to go over COPD because there's a lot of overlap in the medications. Somebody with COPD might use the same medication that somebody who has asthma would use. So I'm going to just talk about COPD and then we'll get to the medications. So for the prevalence, so COPD is the way you guys will learn about it. There's probably nuance to it, but the way that you guys are going to learn about it is COPD is basically a combination of emphysema, which is typically caused by smoking, exposure to chemicals in a work environment. Like if somebody worked, in a chemical plant or in the mines or, something like that, or they smoked cigarettes, they're going to be more prone to emphysema. Those are some of the major causes of it. And then chronic bronchitis, that's a little bit different. People can have chronic bronchitis for different reasons, but when you combine those two, then we have chronic obstructive pulmonary disease, COPD. So chronic obstructive pulmonary disease is a slowly progressive disease of the airway. And it is chronic, but just note the subtle but difference between asthma and COPD in the definitions. Chronic bronchitis, emphysema, COPD presents the fourth leading cause of death in the US. I should double check that. I knew that that was what it was last year, but I always like to, all of those statistics can bounce around slightly. So I always like to make sure that I'm saying the right thing, but that was true last year. Um, it's probably still pretty similar. Etiology, COPD, most important cause is the cigarette smoking. It accounts for 80 to 90% of COPD. And then and still it's it's smoking old school cigarettes. I actually feel like it's making a resurgence. I see way more people smoking like old school cigarettes than like like a vape pen. And so I'm like, is this coming back? But it felt like for like a decade or more, you just didn't see people smoking as often. But despite the risk, about 1 in 5 smokers will develop COPD. My dad smoked for decades. He has mild COPD. He's in his 70s. And he doesn't feel it as much because he lives in Arizona. It's real dry. And the emphysema, that he had some emphysema in it, like a portion of his lungs, and it just wasn't real severe. And he stopped smoking in his late 50s, I think. So he's hasn't smoked for a couple decades, but the damage is still done. And this kind of just shows some of the damage. You can't read it, but it's basically it destroys the alveoli. And there's some other things we don't really talk about exactly how it happens. But that's essentially what happens is the nice little sacs that exchange oxygen and carbon dioxide, they get destroyed. The little alveoli sacs. So it kind of says a little bit. So lungs with COPD, bronchioles lose their shape. They become clogged with mucus. The walls of the alveoli are destroyed, forming larger alveoli. And just, the oxygen exchange is just poor. So with chronic bronchitis, which is that, emphysema bronchitis together, we got COPD. Changes in the bronchial wall, thickening of the bronchial walls, increased size of mucus glands, lot of like productive cough, sometimes with someone with chronic bronchitis, obstruction caused by narrowing of the airways, increased sputum mucus, mucus plugging again, just kind of plugging up all those little airways, and then collapse. So we just aren't getting the filling of oxygen and that, that exchange, that breathing in and out exchange. So for emphysema, so smoke injures the alveolar epithelium. We have an inflammatory mediators, neutrophils. They're attracted to this destruction. They kind of want to go save the day. It's like kind of like with perio. You get, a breakdown, you get that inflammatory. They go to kind of help, but really it ends up kind of making it worse. The neutrophils release an enzyme that destroys the alveolar walls. The airspace enlarges, you lose elasticity, and then they get airway collapse. I don't think I have an exam question on this. I just think it's kind of interesting. I think I put that in there because I was like, it's kind of almost like perio sort of ish. You just get your body tries to fix something or tries to address something, and it just sort of makes it worse. And again, this is very complicated. It talks about inflammatory markers and things like that, neutrophils and enzymes. You do not have to memorize this. It's for interest's sake and to make you never want to smoke a cigarette. But you don't have to memorize that. Okay, so a lot of times the signs of COPD is going to be cough, usually a productive cough. Patients do tend to be at this point when they have chronic COPD that's a little bit more advanced. They do tend to be more sedentary, potentially overweight. Cyanotic is like a bluiness to maybe their nails, maybe even like their lips. They might carry oxygen potentially, but not necessarily. It just depends on the stage. Edematous, if they don't have good circulation, they could have swelling, breathless, taking a walk, certainly going upstairs. For emphysema, there's going to be that difficulty breathing. That's the dyspnea. Enlarged chest, weight loss as the disease progresses. Cyanosis usually not seen. When I was real little, we had a neighbor, and he was just that old timey chain smoker. Like I was little, and he was probably like in his 60s, and that was like in the 80s. But he was so skinny. He had horrible emphysema. He might have even had lung cancer. I don't know. But I remember like my mom was like, we gotta go visit Mr. What was his name? It started with a W. I can't remember. And she'd bring him something and we'd go into his dark, smoky house and he'd be on oxygen. It's probably smoking a cigarette. I'm sure he still smoked. I'm sure he did. But his daughter babysat me. His older daughter, she was like in her 20s, but anyways, it was just like I just have that scene. But he was very skinny, but he was very advanced. And who knows, I know he had emphysema or something, but I think he could have even had um okay. So couple more symptoms. So ongoing cough, cough that produces a lot of mucus, sometimes called the smoker's cough. It's oftentimes some of the first symptoms of the condition. Shortness of breath, wheezing, chest tightness, and a heaviness. So all the things you kind of would expect if your lungs aren't working very good. Now for COPD, there's not a lot of like an outright cure. There is therapy. So oxygen therapy, there's some other therapies. I wonder if I have it on the next slide. Obviously quitting smoking is going to be one of the main things. There is pulmonary rehabilitation. That's probably what. So there's respiratory therapists in hospitals, and they have nebulizers and different equipment that I think, does some kind of therapy on the lungs. Some people have to have surgery, remove parts of their lung if they're really bad. And then there is pharmacological management that we'll get to here in just a second. Okay, so here's the meds. So the rest of the slides mostly, I think, talk about the meds. So for the most part, I have no idea how much time do I have? Like less than 20 minutes. Okay, we should be good. I think we'll be fine. Someone yell at me if it's like 2:50 and I'm still talking. So for asthma and for COPD, you can see there's a little bit of overlap. The beta-2 agonist is a major overlap, and then the corticosteroids. And then for asthma, we have leukotriene receptor agonist, muscarinic receptor agonist, and then we have different anticholinergic meds that someone with COPD might take that I don't think necessarily somebody on asthma. But last year I remember doing a little bit more of a deep dive into some of the medications, and many of them said like either or. They said could be used for either or. So doctors prescribe meds for different reasons, and some doctors do off-label medication. They'll prescribe something that's meant for one thing, but they know that it'll benefit, so they do stuff off-label. So here's the drugs, some of the drugs. The one you for sure are going to get tested on, you for sure want to know, is albuterol, ProAir, Ventolin. Those are two brand names. It stimulates the beta-2 receptors, so it stimulates that bronchodilation. It is short-acting, and we pretty much kind of refer to it as like the rescue inhaler, kind of what it's called. And then there can be some adverse reactions of like jitteriness, nervousness, dry mouth, dry throat, and irritation in the throat. And then it can increase heart rate. So that contractility of the heart or the heart rate. And then for the dental implications, the dry mouth. So what you could tell if you have a patient that's using an inhaler, they complain of any of these side effects, you can say rinse your mouth after you use a spacer. And I think I have a slide of a spacer, what that is. And so it would help get the medicine down into the lungs and not hang out in the oral cavity so much. But you can also tell them to rinse their mouth right after they use the medication. And now we have, so that's a short acting, so that's your SABA. And now we have the LABA. So it stimulates again the beta-2 bronchodilation, olodaterol, Striverdi, Salmeterol, Ceravent. And so those are long-acting beta agonists. That's more of a maintenance. They might just have to do it once a day, twice a day. They just have to do maintenance. They have to do it regularly because they know if they don't, an asthma attack could be triggered easier. Again, some similar nervousness, dry mouth, dry throat, faster irregular heartbeat. dry mouth, have your patient rinse to prevent that. And then another one here, the formoterol is another LABA or long acting beta agonist. Okay. Axon beta receptors gets us to bronchodilation, opens things up. That's what we want. Most effective bronchodilators, duration, short and long acting, just like we saw on the slide. Onsets is minutes for the rescue inhaler, but might take a little bit longer for the long acting. Adverse effects, xerostomia, increased heart rate, nervousness. We already kind of covered that on the other slide. Okay, here's a new one, corticosteroid. This is a maintenance, and it's meant to help with inflammation, control inflammation. So reduces inflammation, inhibits the release of those inflammatory substances or inflammatory markers. The potency can be low to medium to high. So different drugs will have different potencies. And so for that one, adverse effects for the corticosteroids, they can also be an inhalant. You could get a corticosteroid inhaler. And one of the main, this one, notice it's highlighted because you're probably going to get a question. One of the main oral adverse effects could potentially be oral thrush or Candida albicans. Pharyngitis is another adverse effect, a dry cough, dysphonia, hoarseness, all these dys words. Systemic, there's tablets, so swallow a pill. Systemically, there's short term if they take the medications that are more systemic than localized. They might have insomnia, nervousness, increased appetite, impaired glucose. So if they're diabetic, that could be an issue. Long term, the Cushingoid feature is like a Cushing's disease is a condition. And so Cushingoid features is like things that resemble Cushing's disease. Parchment-like skin, so skin thinning, that's what they always warn. Like if you have a strong steroid skin cream that you have to use for like really bad eczema or something like that, they say it can thin the skin. So it's the same thing. Something's taken systemically or topically. Leg edema, sleep disturbance, poor wound healing. We know that our corticosteroids can compromise our immune system. So it would affect wound healing, impaired glucose, sodium, water retention, hypertension, osteoporosis, fracture, glaucoma, and depression. Doesn't that sound great? So there's a lot of medication, a lot of conditions that people might have to take a steroid for. And so one of the hardest things is if somebody has an autoimmune condition and they have to do heavy long-term steroids, there can be a lot of negative systemic effects. And so that's kind of like lumping them all here. And we'll talk about some of them in some other, like in our autoimmune section. But like a prednisone or something like that, you don't want to be on those long-term, but some people have to because of the condition that they have. This is a picture of the spacer. So you would adapt the inhaler to the end, and then you would deposit the medicine, and then you would take a deep breath to get it down. So it holds the medicine in the spacer, and then you take a super nice big deep breath and it just shoots it down into your lungs. So it minimizes the amount of medication that's in your mouth and how long it stays in your mouth. So that's what that spacer is for. Okay, so some of these meds, these inhaled corticosteroids, Flovent, fluticasone, Pulmicort, Advair, you guys, that's kind of a popular one. I've seen Symbicort, you might have even heard like commercials. I feel like there's a Symbicort commercial. They're all long acting, and the main thing that you need to notice is that these two, the first two, Flovent and Pulmicort, are just corticosteroids. But these combos are beta agonists. So you're gonna recognize which ones do we recognize as our beta ones.
The
Yeah. So that's a good way to do it. Look at those endings of how those words end. And then that'll help you. So here's our beta agonists. These are our corticosteroids. So they're combination medications. There's probably a question on them on the exam about that. Okay. And so then we have a pill. Prednisone is, there's others besides prednisone, but that is a very long-standing, popular systemic corticosteroid. Reduces or prevents inflammatory processes. Hyperglycemia is an adverse reaction. Osteoporosis, fluid retention. Dental implications, it suppresses the adrenal gland. It affects wound healing, infection more likely to be masked in these, if you're taking an anti-inflammatory. And then we have leukotriene receptors. The only medication there that I'm going to ask you to try to remember is the Montelukast or the Singular. It's for asthma, but it could be used for other things. Blocks leukotriene from binding to the receptors. And then there are some adverse effects, but not super orally related. Anticholinergic. So Atrovent is a pretty, I've seen patients who take Atrovent. It's an anticholinergic, so it blocks cholinergic receptors in the smooth muscles. So it's gonna block probably muscarinic, I guess, is what I'm assuming, but I don't have that written there. But the low anticholinergic effects, which is good to note, there can be nausea and then occasional metallic taste. So short acting and long acting, Spiriva or Atrovent, and they're inhalers. Anticholinergic inhalers. And the thing that's nice about those is that it kind of says the mechanism of action in the name. Oh gosh. There's a lot of writing on this slide. This one is just, again, whenever I find these types of slides and it's not so much that I need you to memorize it, but now that we've looked at leukotriene agonists, and you can ignore this one because we didn't learn about theophylline, but mast cell stabilizers, sympathetic agonists, corticosteroids, so, histamine. So if you read through it, you will find some overlap in what I've talked about in other slides. It's not like you're supposed to memorize this whole slide. Sometimes I'll pop in things that, could help you kind of put it all together. Just another way to think about it, I still recommend the flashcards, but you still need adverse effects, mechanism of action. So like albuterol, axon beta 2 receptors, bronchodilation, xerostomia, increased heart rate. And we're not going to do that because I feel like our brains are or maybe we'll just talk it through. Patient with moderate persistent asthma, allergic rhinitis, taking an allergy med, taking a combo fluticasone. What's that? What's fluticasone? Inhaled corticosteroid, and then salmeterol is the beta 2, yeah, beta blocker. And then they're taking sort of a maintenance inhaled corticosteroid beta, and then they have a rescue inhaler that they use every once in a while. So symptoms: white buildup, lining of the upper palate. What would that be? Candida, yeah, Candida, and it's on the tongue and the back of the throat, and you can easily remove it with gauze. So that's the Candida. And then what's probably the cause of it? Is it the corticosteroid or the beta blocker that's causing the thrush? Steroid, yep. And then what could you tell them to do to help prevent that? Use a spacer and rinse your mouth. Those are two things you could have them do.
Rinse right after.
Yeah, rinse their mouth right after. And then if they use a spacer, it'll get the medication down their throat into their lungs instead of hanging out in the mouth. So, okay. I think that's the last one. Nope, just kidding. Another patient. So try to answer that one. I think I have the answer in the notes. It has to do with exercise-induced asthma. But, this is the one where their albuterol is expired. So I think the answer is maybe they need a new inhaler because their medication's expired. But okay, that's it. We'll end with that. So you guys can have a little run around. Oh wait, do you have Spanish in here? I know you're all exhausted.